Matt Disney has come up from Florida, and this is part of a longer trip. He'll be going down to Philadelphia. He's just discovered that traffic in New York City is not as quick as he might have thought. So he's only going to be here for a few minutes, and I'm just going to say thank you before you go. The way we're going to work is people raise their hands, a microphone will come to you, and you're asked your questions. And if you have specific questions for Matt, we'll start with him. I'll actually ask the first question, but please raise your hands and the person with the microphone will come by. She's standing up right there. So Matt, I was very interested about what you talked about with cancer, with the microRNAs kind of covering pathways. Do you have any sense that there are pathways, genes that are co-regulated similarly across the genes we're thinking about of autism, or is that too early to say?
We have not looked at it, but I think given the computational tools that are now available for microRNAs, I think it should be pretty straightforward to be able to figure that out. I am not aware of any clinical compound targeting a microRNA that's been put into trials for autism spectrum disorder. However, for autosomal dominant polycystic kidney disease, Regulus was just acquired by Novartis for a huge amount of money. So I think there's interest in microRNA targeting molecules affecting pathways in large pharma now.
Thank you. Who has the mic? It will give it to somebody.
First off, thank you very much for having something for people with profound autism, because it's so hard to find any kind of research for our community. The other question is if the PKU diet can help people with self-injurious behavior. Has it been looked at with people with autism?
So I think the answer is no, but the PKU diet is because there's a specific enzyme completely missing, and so people metabolize amino acids differently. And so they just take those out of the diet, and then you don't have some of the toxic byproducts of metabolism. So it's specifically for people that have this loss of all functional copies of the enzyme. So great question though, but this is precision medicine. Sometimes it only works for the subgroup.
Hi. It was a terrific day, and a lot of the information and the trials were really well thought through. I have a question in relation to that. Some of the trials had only 2 people or 4 subjects. Obviously, the smaller it is, it calls into question the results. Why are the trials sometimes so small?
Take it away, Alex.
It's a great question, Mark. There's a lot of reasons. I think, first, doing a large trial is a huge commitment, both in terms of time, burden on families, and of course, money. So I think it's really important to get some initial, pilot data, basically. And so generally what happens is, that's what you saw with the pathways we described, where there's kind of a small trial in an academic environment, typically with, one site, maybe doesn't even have a placebo control. And then hopefully another trial, continues to provide some promise. And then industry comes in with all the money and says, okay, we are committed to bringing this drug forward, and we're going to do what's called a phase 3 trial with multiple sites, placebo-controlled, and we're going to register it with the FDA to attempt to get an approval.
So a small trial can convince industry that this is worth further investment.
Exactly.
And more than that, some of the really small trials that were presented here, they're really just first safety trials. So the Jaguar trial that Alex talked about, you're putting something in the brain of a child for the first time. And so you do that with great caution and very slowly.
I have a practical question for you. I'm a general pediatrician, and I have a number of families who have been dealing with autism. and parents approach me and ask, genetically, what can I do to ensure that I will not have another such child? They're probably referring to prenatal testing or testing of the father and mother, whether or not the family history is positive or negative.
Go ahead.
So every child with autism should have genetic testing. That's now standard of care. And that would include Fragile X testing, a chromosomal microarray, and even whole exome potentially, if those are negative. And then if you find something, it actually may give you a sense of what the recurrence risk is of the family. Because generally speaking, the known autism genes that we have are de novo spontaneous, meaning any siblings at no greater risk than the general population. So obviously, if you have one child with autism, the risk in general of having another child with autism is like 15 to 20%. But if you find a specific gene, you can really adjust that risk accordingly depending on the inheritance pattern.
Thank you, Matt.
Oh, he's going. I had a question.
Oh, that's it, Matt. Okay.
Sorry, I just had a simple question. Is your target the binding protein, the RNA, or the complex?
It's most likely the RNA, but we have the tools to be able to figure out if it is the protein and the complex. But I suspect it's either the RNA only or the RNA protein complex.
Okay, thank you.
Thank you.
Hi, my question is for Paige and maybe for Alex. One of the issues we have with clinical outcome measures in the population for profound autism is that our kids typically fall below the floor on the standardized measures. Those measures were not intended to measure someone with IQ below 50 who's 27 years old. So is it time for us to come together as the profound autism community and say, it's time for us to create a profound autism diagnostic instrument that could also be used to measure the effectiveness of intervention in the population of people with profound autism?
Great. Sorry, can you hear me? Great question and great idea. Yes. I mean, right, we're using measures, some of them that haven't been updated in 30 years, right? The motor skills, for example, that are on these measures aren't necessarily applicable, right, to individuals who are older with profound autism. I think, you know, when we talk about sort of the challenges of large enough samples and proper validation, I think the question is sort of the how, right? Yes, we need these tools. How can we do it? And sort of the patience that this will take time. But I certainly think that we do have enough existing data that we could sort through and figure out which of the items are applicable, right? And what's missing. What are motor skills, daily living skills, cognitive skills that these older individuals with profound autism are using on a daily basis, right? And how can we integrate those? And so I think, yeah, it's a great idea and would be a huge step, I would say. A big idea, but a great one. And a great one, I should say.
I mean, I'll also say that there are a number of specific genetic forms of profound autism now that are developing their own measures, to your point. So Angelman syndrome, Phelan-McDermid syndrome, Rett syndrome. There's still behavioral measures, but that's a really important effort because those are kind of adapted and refined specifically to the phenotype of these kids. And then the other thing I'll say that I'm sure came up this morning is biomarkers, right? Objective ways of measuring change is you know, that's the holy grail, and everyone's working on that.
So raise your hands, and meanwhile, I'll just, I had a question for Fred. I love the idea of looking at multiple genes at one time, and obviously we're collaborating on it together, so I'm not just saying I love our ideas, but the idea of knocking down 100 genes and then looking for, you know, shared pathways. So my question to you is, what is the, for lack of a better word, dynamic range of the organoid model? Like how complex, how many, you know, you've shown, for example, that the PAX6 staining can be smaller or larger, but how many more dimensions can you look at?
hold your microphone close to your mouth. We can't hear you.
So we've already been told that we should turn with the microphone. Of course, I didn't listen.
That's good. I like that. Right? Like
And
that.
apparently, other speakers after me were told, don't do what Joe did. Don't look up at your own picture. So I am the exemplar. So the question is, right, if we have 100 genes and we want to try to break them down into overlapping, developmental pathways, what's realistic for your organoids, for example, for a given model? How many dimensions can you really capture, for lack of?
Yeah. So we'll find out very quickly first, but I think so. For example, there is this technique that has been developed by another company called cell painting that I think has been used by many drug hunter in the past for various diseases. And people are looking at single cell and looking just at the behavior of single cell morphology upon certain perturbation. What they found out is that actually the data set that they will generate was very rich. Right? They could actually cluster many different pathways and do this exercise in a very profound way. So in our specific case, we're looking at a multicellular tissue, which is way more complex, which has way more granularity. So I hope that we can at least, rise to the level of cell painting and go beyond. And then we can add, more components. We can add more tissues, different tissue types that will probably different biology, maybe more orthogonal biology, to add more resolution. And why not actually more organs? I was just discussing with a family of a patient. So that disorder that impact not only the brain but many organs, and that's something also that we can add to the game, to increase resolution.
Thank you. Questions from the audience? Somebody, yeah.
One, I wanted to speak to her comment regarding evaluations. I work in the school setting and education. I do the evaluations, and I do think it's important that the tools that we use to look at autism is reflective of the skill set. And I often tell parents when I'm sitting on those CSE meetings that the tests do not accurately reflect that child's cognitive ability. The test cannot measure what it is that we're looking for. And I do believe, all of these years that there should be something. I know some instruments are a little bit better than others in picking up subtle nuances of autism or the child's cognitive ability or their crystallized or fluid intelligence, but the material should be better developed. I took a look at the sand outside, but I saw that the age range is still limited. I work with pre-K through 12th grade, or to 21 or 22, because in the school setting they can have an IEP to 22. But I also wanted to comment regarding research with people of color. I found that a lot of the material that was presented today was very Eurocentric, and I think it is important because more and more children are being diagnosed of color. I sit on CSE meetings 4 days a week, every single day, and so many children are being diagnosed with autism. I think the tools are a little bit better now. We're picking it up more. It doesn't mean that that population didn't exist, but there's a lot more information that's out there. So I had just wanted to make those comments, and I was curious, I know Pilar spoke on that, regarding how do you outreach to that particular population, because sometimes trust is an issue in diverse communities. And so what is your organization or the industry as a whole doing to build those bridges to those various populations? And rather it be people that are from the African diaspora, the Latin America, or the Arab population, because I'm seeing autism across the spectrum in many different populations, and it doesn't discriminate from anyone. Thank you.
Thank you. I can start with the end because I only remember the last question of the So certainly we are not doing a good job across diverse populations, across diverse socioeconomic status, not only in terms of diagnosis, but also in terms of access to care, right? And so we at the Siper Center do have international efforts you've heard about Latin America, also setting something up now in Tibet, where we've had some families reach out to us. The NIH has been funding addressing ancestral populations across psychiatric disorders. They put a lot of resources into African Americans with autism. As you pointed out, recruitment was not as robust as people hoped, and it's because of the history of 400 years of oppression of people of color. That's changed now. The Gala study that we talked about is specifically outreach in Latin Americans, which are admixed, often including African ancestry, in the US and South America and Central America. And we believe that this year there'll be 2 major papers, one on autism in African Americans and the other one on autism in Latin Americans, to help address this and to just ask even if we have the right tools. So definitely agree it's a major problem. Definitely agree it's a focus of our group, and it has been a focus of the NIH, and we're all quite worried that that might be reduced in emphasis, although the first indications are that it's not being reduced, that there's still a commitment to make sure that we have better representation in autism across ancestries. But early days on that.
Okay, I'm going to get to your first question, but I do want to mention, because I don't think it's come up yet today, that here at the Siper Center, any family who participates in research does get a full evaluation free of charge with recommendations, and so you probably have some families who have come through, but I just do want to mention that, and it really does allow us to see as diverse a population as possible. To your point about sort of the normed assessments, right, and so, there are certain assessments that, and again, I can't speak to sort of the Board of Ed and right, the sort of stringent requirements, but that are used, including in research studies, outside of the normed range where standard scores or developmental quotients are calculated. So using measures that, rather than just saying, the individual has raw scores of 0, they can't, complete this assessment, we are able to sort of drop down and look at certain assessments and provide, whether it's age equivalence or, some meaningful standard scores. And so, yes, there are limitations, certainly, to all of the measures, right? But I do think having that flexibility, even if it's not what, the Board of Ed is looking at, but being able to at least provide families with that context, right? Especially looking at changes over time when raw scores are increasing, even if the standard scores are flat or dropping, improvements happening, gains are being made. And so I think it's a broader conversation than what you just see on those standard scores.
I want to add that this is also where I think advocacy from everyone that is in this room is important. So you have, these agencies, and as we know, sometimes they're there and sometimes they decide they are not. But in my experience, when I've worked, and mostly for obvious reasons with families from Latin America, but when you explain when you kind of share the knowledge that we have, why this is important, why participating of research, if it's available, is critical, what is getting on the way, and then having or helping give many of these families a voice, including what you're talking about, outcome measures and how the growth of their children is going, how that plays in those conversations as well. Maybe there's times where you actually want those scores to come down if that means that they will get more services, and that's what we are looking for. But I think it's a wider conversation, and I think one of the things I was trying to share with you is that I think to an extent this falls into everyone. This is not going to change if we are only assigning kind of the responsibility on a funding agency. This needs to start with us because it's the right thing to do, because it advances science, because, a number of different reasons. But we have, we are here, we have a special interest, but also sharing why this is important. And advocating for those changes, I think, is very critical.
So, Rachel, I have a question for you. You have this really interesting compound, NNZ 2951, or cyclic CGP, let's call it that, right? And you have evidence that it's working in multiple kind of phase 2 trials, and you're beginning this big phase 3 trial. When do you pivot and think about, let's say idiopathic autism or idiopathic profound autism, and say, even without a genetic biomarker, can we identify a subgroup that's responsive to our compound? Just curious.
Yeah, that's a great question. And I'm going to wait for Paige to figure out if the biomarkers work. VEP, maybe if we can see in small trials that VEP is changed in, with NNZ-2591, then we can start applying it to certain subpopulations of idiopathic autism as well.
So you are looking for other biomarkers besides the genetic one that might be able to subgroup idiopathic or non-idiopathic autism, and then target the subgroup that's defined by an EEG biomarker.
Exactly. We're just waiting for you guys to figure it out. So.
Oh, okay. Okay. Come back next year and we'll. Questions from the audience? We're going to take a couple more questions and then wrap up.
So for PMS, it's very exciting, all of the new drugs that are happening. And I understand that with the neuron drug, it's more of a systemic, you take it orally, it kind of goes everywhere, right? The Jaguar drug goes into the brain. And I'm just curious, as parents, it's a little scary. It seems like a high-risk, kind of high-invasive procedure. And so with this being a pilot study, and we're just starting out with a couple of kids, in the future, will that always be an ICV administration, or will you go to something more IV-related going down?
I agree. It does sound scary. And yes, it's definitely higher risk than taking an oral drug, or it depends on the oral drug, but it's certainly higher risk than NNZ-2591. And the purpose of this first cohort of kids, there'll be 6 of them, 3 at a lower dose, 3 at a higher dose, and it is mostly designed around safety. I mean, there's still going to be critical outcomes of efficacy, and if those are successful, the idea would be to do a much larger registration trial. This method, this drug, would be intracerebroventricular, into the brain. There are other ways of delivering disease-modifying treatments, like people talked about the ASOs, that are potentially through like a lumbar puncture or intrathecal, or even potentially intravenous, but that's not what Jaguar is doing. There may be other ways. I mean, if you look at the future of science, there's going to be all kinds of what now seem to be science fiction ways of delivering gene therapies that we'll be looking back and saying, oh yeah, obviously that's how you do it. So this is a nice kind of cool evolving field. Yes. At the same time, AAV9 has been used in other gene therapies. It's been safe, it's been successful, and so far it's been promising with our one single kid. But yeah, there's a lot to learn.
And just a quick note, not all small molecules are brain penetrant, but NNZ is, so it's 100% orally bioavailable, which is our jargon for it gets across the blood-brain barrier.
I guess this is a question for Dr. K from Jeannie Rice. She wanted to know what the availability would be for maybe IGF-1 for ADNP, to use it for ADNP.
IGF-1 for ADNP syndrome. So let's see. ADNP is complicated. It's a transcription factor.
I know.
Yeah. It's a little bit more complicated in terms of like affecting lots and lots of other genes. It's not a scaffolding protein. I wouldn't say no, but it's not an obvious choice. First of all, IGF-1 is almost impossible. So we're looking more at like IGF-1 analogs or metabolites, things that hit the IGF-1 receptors or things that unbind IGF-1 to free it. So I think, like Neuron's molecule is going to be relevant for a number of different single gene forms of autism. Not sure that ADNP is going to be a high one. We have other things we're working on with ADNP, however, as you know.
Thank you.
So maybe I just want to follow up on one comment about the SAND. It's true that right now it's approved for a certain age group, but that's just because it's early days, right? You're working on...
So we've published on it outside of the age range within profound autism across genetic syndromes. The measures, if you're looking at an individual 12 plus without profound autism, while the questionnaire would be appropriate, some of the materials might feel a little juvenile, which is why we published that as the initial sort of target age range. We also have infant data as well, starting at 6 months old. So it's appropriate for use across ages, and we've published in the genetic syndromes with even adults, and have data that's very helpful in terms of sensory preferences. But the sort of clinical cutoffs were based on that 2 to 12.
And what's the correlation between, the sensory activity, as you pointed out, if you see something in a 10-minute period that's really, disruptive to attention, interaction, so on, it's going to have a quality of life issue and an issue across the day. But what's the correlation of other clinical measures with the SAND?
So looking at the SAND and other sensory measures, we see nice correlations. We also see correlations with autism diagnostic status, right? So even though the SAND is a 10-minute observation and 10-minute interview, it's pretty apparent based on how the individuals interact with the materials, whether or not they're going to ultimately meet criteria for autism, and that data is very strong. And just sort of as an example, when you're doing the SAND on controls, there's a lot of imaginative play that goes into sort of their interaction with the materials. They're referencing, they're showing, they're sharing. And so even though it's intended as a measure of sensory differences, the diagnostic utility of it can also be helpful.
And does it correlate with other measures of severity?
Like what?
I don't know. You're the
What did you have in mind?
Well, I mean, for example, other behavioral challenges like attentional challenges or, irritability.
Good question. So we're collecting data now in ADHD. In the data that we've looked at just within an autism sample of those with and without ADHD, we see high rates of sensory reactivity differences across the board. And very, very preliminary data in ADHD alone, we also are seeing high rates of sensory reactivity. The SAND does sort of ask about and target certain very characteristically autistic sensory differences, but still capture some of those that are more broad that we're looking at now in other neurodevelopmental disorders.
Thank you. Final question from some brave audience member? It's okay if, it's not that you're not brave if you don't ask a question. Let me rephrase. Okay. So I think given it's been a long day and you have all been incredibly patient, I think maybe we want to thank the speakers one more time for, I think, some really, really remarkable talks.